We've had various mention across the morning of regulatory issues, and so now we have a group that can talk specifically to those matters. As kind of first to launch the session and kind of give an overview, we'll have Dr. Mark Merrick, who is currently the Vice Chair of the Ohio State Biomedical Sciences Institutional Review Board, and he's also the Director of the Athletic Training Division in the School of Health and Rehabilitation Sciences. And then joining him on the panel will be at the end there is Dr. Karen White, who is the chair of the Nationwide Children's Hospital Institutional Review Board. And she brings to that position over 20 years of experience working with both pharmaceutical and medical device companies seeking FDA approval, among other aspects of the clinical research industry. And also Sherry Petty, who is a certified IRB professional and a quality improvement specialist with the Office of Responsible Research Practice. And before that, she offered administrative support to the Social and Behavioral Sciences Institutional Review Board. So all of our presenters bring a great deal of experience with the IRB process, and so welcome all of you today.
Thanks, Stuart. So I'm Mark Merrick. I'm Vice Chair of your Biomedical Sciences IRB. We have several IRBs here at OSU, but most of the research that is biorepository related either winds up through our IRB or the Cancer IRB in some cases. So we're going to talk a little bit about regulatory issues. This is where we get to be the bad guy. Now, this is where we are the barrier to you doing the things that you want to do for medical innovation and to change society and improve the health care of people. And really change their lives. And if by the time we get this done, hopefully you'll see the balance between those things and protecting the particular participants' rights and interests as they go through these studies. So a few objectives in this talk. We want to talk a little bit about some critical regulatory guidelines for biospecimen and data repositories and related research. And by the way, when you think about this on the big picture scale, specimens and data are really the same thing. All the specimen is data in a biological form. So we don't necessarily make a lot of distinctions between those things. We'll talk about some definitions, particularly the ones that trip people up most frequently, a little bit about guidelines for usage of biospecimens and usage of data, and some guidance on collaborating on some projects about those kinds of things. So whenever I start a talk like this, I like to start with this slide. The things that we do on the IRB side of the house are really research risk protection and participant protection, and the underwriting principle behind this is an ethical one, not a regulatory one. You know, the purpose of regulation really is to hold people accountable for ethical decisions. And the key elements of ethical decision making when it comes to biomedical research are really sort of outlined in the Belmont report. Many of you are familiar with it. You may have never seen the cover to it before. But three big principles here. The first one is beneficence. You know, do no harm and maximize possible benefits to the research participants. Justice, treating people fairly, treating people equally, and protecting vulnerable populations. And respect for persons, acknowledging that they have their own autonomy and ability to make self-determining decisions for the things that they want to be involved in or not involved in, and to protect those who have diminished autonomy. So as we look at biorepositories from a regulatory standpoint, the regulations are what they are, but the regulations are always in flux. The underwriting ethical principles, however, aren't. And this is really the lens through which we're going to look from a regulatory standpoint at the things that investigators do with biorepositories. I think it's helpful in this framework to understand a little bit about the IRB's role and how it's different than sometimes investigators perceive it to be. The IRB is not the institution, and sometimes that's not clear on its face. The purpose of an IRB is protection of the welfare, safety, rights, and interests of the research participants. Different than the purpose of the institution, whose really their role is to protect the rights and interests of the institution and its investigators. So we work for different bosses in that regard. IRBs are functionally a community-populated board. So our IRB is not made up solely of research investigators from the institution. We certainly have scientists, but we also have a lot of non-scientists, and we have non-affiliated community members on our boards as well. In some cases, those members have specific roles and responsibilities. For example, if we're looking at research that involves persons who are incarcerated, we have a prison representative on the board whose job is to protect the diminished autonomy of people in that setting. So it's a little bit different than sometimes people think, where we're a group of peers and colleagues and investigators thinking about things in an investigator kind of way. In many cases, IRBs have been delegated responsibility for HIPAA oversight that is related to research. That's not an inherent thing in an IRB, but in many cases, we become the de facto HIPAA board for research-related things, and Karen's over here nodding her head, so that's really at both of our houses. Right. We wind up doing that. Institutions do something different than an IRB. You know, institutions really look at creating policies and processes that are favorable to its financial bottom line, its ability to attract and retain faculty, its reputation, its legal risks. They're internally focused with an external goal. IRBs are really more externally focused, so our frame of reference is a little bit different on these. So as we jump into biorepositories, data and specimen repositories and banks range in size and scope. Everything from every researcher has that old freezer sitting in the corner of the lab with chunks of people in it, to massive scale biorepositories that are organized, that are systematized, and that are searchable and you can do amazing things with. All of those things functionally act as a biorepository. Some are better than others, and as we evolve, our processes get a lot better related to those. If you want to create a data or biospecimen repository for future research purposes, for things that are human research, you're going to have to go through an IRB for approval. Not everything in a biorepository might be human research, and that's something that we'll jump to here a little bit later. So some key elements of a biorepository protocol that you're going to submit to an IRB, whether it's ours or nationwide, or really almost any IRB nationally that you're going to go through, you have to have a purpose for the collecting and storing of these specimens. Now, sometimes the specimens are collected in the context of a single study and retained for future use. Sometimes they are collected purely for future unspecified use, only to go into the biorepository and aren't necessarily part of a particular study right now. You're going to have to define the types of data and specimens that you'll be collecting and storing, the source and circumstances by which they were collected. So were these things that were knowingly donated by a participant for participation in this study? Are these remnant clinical samples that are from the PATH department after they've gone through testing? You have to have some good definitions and understanding of where are your samples coming from. How are they going to be stored? That's not just physically in terms of, do you have adequate storage facilities to maintain the integrity of your specimens, but how do you link those specimens with the data that goes with them? Are these identifiables? Are they coded? Are they de-identified? Were they anonymously donated? And by the way, there's no more confusing thing in IRB speak than coded and de-identified. People get this wrong all the time, so we'll spend a little bit of time on that. If the data include individually identifiable protected health information, there was a time in the not too distant past when the large biorepositories were mostly de-identified because it was easier to do it that way. And what we're learning, and as you've already seen from some of the talks today, it's not just what's in the sample that's important. It's the things that go with that. It's the patient's electronic health record. It's their outcomes. It's their phenotypes, not just their genotypes. Without that other ancillary information, the specimen is far less useful. So you're seeing more and more biorepositories go to the identifiable route rather than the de-identified route. What's the physical location, storage, and security provisions? How long are you going to store these? Is it a finite defined time, or is it an undefined time? All things you have to think about. Some more things. Are there limits on the data or specimens' intended future use? If I donate a sample and it's in the context of a cancer study, and I'm donating this research and my consent form says for future cancer research, then that's what it's good for. Even though those cells somewhere down the road, we might identify, wow, you know what? There's something about these cells that might make them useful for Alzheimer's research. Well, they were donated for cancer research, And that's the spirit and intention with which they were donated, and that's how they're going to have to be used. With whom can you share these specimens, including non-Ohio State people? For example, do you want to collaborate with someone at a different institution? We do that all the time. What about commercial use? Can this institution sell your samples to a company who wants to use them to produce a product? Those are things that would need to be considered. The process by which those people might request and release data and specimens, can they then release your specimens to a third party? Or are you licensing them only for use by that secondary party? Some things you need to look at. How can participants withdraw their data and their specimens from future research? At some point, people change their mind. I gave a talk on biorepositories last night in a graduate research course on biorepository ethics. And one of the people said, you know what? I'm really worried that they might try to make a clone out of me. Well, we're not really doing a lot of human cloning these days, but it'd be nice if we could, from a scientific standpoint at least. But people are worried about those kinds of things, and they may decide, you know what? I don't want my stuff in your freezer anymore. So how do they get it out? And can they also withdraw the derivative knowledge that's been obtained from use of that sample? Who has ownership of that? Issues that you have to consider. How are you going to continue biorepository operations in the absence or departure of the principal investigator? People change institutions all the time. We see tons of personnel changes because somebody has come or somebody has gone. They're bringing their specimens with them. Their specimens are staying, but they're leaving. What happens to those specimens in that repository? How is it going to be managed going forward? Having a succession plan is really an important thing when you conceive the biorepository, not when you have to scramble at the end. How are you going to destroy or de-identify coded or data specimens at the end of the retention period? These are all things that you're going to need to identify. More things to consider. An NIH certificate of confidentiality. A suggestion that's out there is that repositories should consider obtaining one of these. And in theory, this prevents people from being able to request samples from your repository for use in things that aren't research related. For example, I've got a sample of this person in my repository, and they want a genetic test to see if they can identify this person and link them to a criminal case. Well, a certificate of confidentiality on its face gives you a protection from that. Now, if we talk where the rubber meets the road, these things may not work. But they give you a tool to use and some confidence to try to fight it. Whether you'll succeed in that fight, there's no guarantee. Data security. More and more, almost every week, you're reading about a data breach someplace. And some of the data that people are most interested in these days are people's protected health information data. Methods for handling and storing your data must comply with your institutional policies. Typically things like protected servers with firewalls and password access. There's a lot of different things that go into data security policies. You need to make sure that the way that you store your data is consistent with that, particularly when you're working with large data sets. Here's some terminology for us. This is probably what trips people up more than anything else. Data is anonymous when information or materials cannot be linked directly or indirectly by anyone to their sources. No identifying information was ever collected in an anonymously donated sample. I can later anonymize a sample, but if it's anonymously donated, there is no data to connect it to. Now, it may be possible at some point in the future to remove those identifiers, and that's something we'll get to here in just a moment. What most of us do in research when we collect samples is we keep them in coded fashion. What coded means is there's no direct identifier on my sample that links it to this patient. Instead, there's some identifier that we have artificially created and added to our sample, and someplace we have a key that links that code number to the real identity of the donor. Coded data allows us to connect our sample to other information about that patient. If we destroy the code, then there's no longer the ability to connect samples to identifiers. And that's what we would call a de-identified sample. A de-identified sample, the identifiers have been permanently removed, and there's no key that exists anymore. So, the bottom line when we look at these from an IRB perspective is If this participant called me up and said, I want my samples removed, if I don't know which samples are yours anymore, it's de-identified. If I know which samples are yours and I can figure this out, it means I've got a code someplace. I have coded data. You can do it in any way that you find appropriate, but you need to be clear about how you are doing it both to the IRB and to your participants. Another possible thing that you can use is a limited data set. Limited data sets have some information, but most of the specific identifiers that are outlined in places like HIPAA have been stripped off. So name and address, medical record numbers are a specific identifier, by the way. So you shouldn't store samples using their MRN unless you've disclosed to people that that's the way you're doing it. Things that you're allowed to do still in a limited data set, you can have location information like city, state, and zip code. You can have all elements of date. So admission and discharge dates are okay in there. Sometimes that's useful because it gives you a time frame on when this care and sample were collected. You can have unique codes or identifiers that are not listed as direct identifiers. So things that we assign for the biorepository or for research purposes that aren't necessarily their clinical identifiers. So sometimes you can store data as a limited data set. You have some things with it. But here's the problem. When I do a limited data set, or if I de-identify data, the only data I have about my sample is the data we already have today when the sample is collected. But you know what? I may type this sample, and I may realize that they are genotype positive for a particular disease, and they haven't developed a phenotype. They might. What's going to happen to them in the future, and is their future outcome important, and does this sample have value with that other information? That's the kind of things that we're really starting to see, and the reason that people are moving away from de-identified data sets, because it doesn't let you link to future information about this patient. In some cases, you may use what's called an honest broker. An honest broker is a neutral party in the middle between the samples and the investigator who wants to use them. And what an honest broker can do, it can be a person or it can be a system, its job is to collect and collate information, provide that to researchers without identifiers. So it's an intermediary whose job is to strip the identifiers and provide functionally de-identified information to the investigator, although it may reside in the bank in an identified way. So acting as an honest broker is a very valuable thing. We have honest broker protocols here that are related to the kind of information you can go searching so we can find out how many patients have this diagnosis if I wanted to study it. Well, we can get that kind of information in a de-identified way. People who have access can look at it and provide you with a de-identified report of the things that you need. So honest broker protocols are a pretty valuable way for a bank to be able to function. When you do human subjects research with biorepository kind of specimens, you're going to need IRB review and approval in almost all cases. There are certainly a few cases where you don't, and we can get into those a little bit in the panel discussion. But in most cases you do, and in most cases you are going to require informed consent. Our policy here at Ohio State requires participants to give informed consent for samples that go into biorepositories. And that is sometimes a really big hang-up when we talk about participant rights versus making research functional and easier to do for investigators. It would be really nice if everything that was collected in the medical center would be available for biorepositories and available for study. But that removes that autonomy aspect from the participant whose materials are being donated and or studied. For example, if I were to ask you, what kinds of things would you be comfortable with your tissues and cells and samples being used for, I can probably come up with things that would make you very uneasy. For example, how many of you would be comfortable donating samples to be used expressly for bioweapons development research? Not a lot of hands here. That kind of makes us a little uncomfortable. What about if we wanted to do research in my lab about racial superiority? You know what? People have done this kind of research before. And I want to collect your sample so that I can show that white people are smarter than any other colored people you want to find. Well, you wouldn't be comfortable donating samples for that kind of a thing. The intended use for this research is something that people have to be comfortable with. And either they can consent to a specific use, or you can ask them to consent to future unspecified research, where they know that I'm not going to have any say in what's going to happen to my samples, and I don't have the ability to necessarily determine which studies can it be used in and which can it not. And if they're not comfortable with donating under that framework, then they're not a good donor for a future unspecified research bank. Ethical issues are really behind here, and that's some of the important things. HIPAA authorization is typically going to be required for any data that's going to include protected health information using the specific HIPAA identifiers that are out there. The reality is a lot of the stuff you want to collect is PHI, so we almost always have a HIPAA release that needs to happen with this informed consenting. Waivers of consent are a real barrier to looking at the autonomy of somebody in donating those samples, and that's something that really is a hot area of discussion and debate right now. Some secondary research uses previously banked data or specimens that may not be human subjects research. If specimens were collected from a deceased person, that is no longer human subjects research. If the person is alive at the time then those samples are given, it typically will be human subjects research. There's a few caveats to that, but generally that's the way it's going to work out. So, were these post-mortem samples or not? If they're post-mortem, it's not human subjects research, the way that our laws currently define them. Now, you could make me a very good argument that if I take a sample from somebody, it can't live detached from its original host, its original organism, therefore it's not a human subject. Well, the way the laws work right now, if it came from someone who was alive at the time of its donation, it qualifies as human subjects research. Secondary new uses of previously collected data or specimens. This is a really hot area of discussion sometimes. IRB approval or exemption is typically required for secondary use of otherwise collected samples. Some of those samples may have been collected for clinical purposes. Some of those samples may have been collected for previous research purposes. Only the things that are, if they are collected for research purposes and there's a consent form, they have to be used consistent with what is in the consent under which they were donated. Boy, that becomes a real problem when you want to assimilate samples from lots of individual little freezers around campus into a single biorepository. Because they were collected for lots of different purposes, and you have to honor the purposes under which they were collected. So, previously collected data and biological specimens are a place where you can get things, but there are often limits to them that you may not have considered. Non-research collection things, we've taken the policy here that we're no longer giving people a waiver of consent for using samples. And that's something that we can get to in our panel discussions if you're interested in secondary use of some clinical specimens. In many cases, you're going to have an IRB review or an amendment to a protocol if you're trying to add things on and make changes with those. Here at OSU, if you're having a biorepository, our policy changed in the recent past, and we want you to have a separate IRB protocol for the repository that is separate from a research study. So if you're collecting samples as part of a research study and you want to keep them for future research, you need two protocols, one for the study, one for the repository. If you're collecting samples for use in a specific study and you're going to destroy them at the end of the study and not keep them for future use, and the use is only related to things you've identified in the current study, that's really not a biorepository, and that can all exist under a single protocol. Research with previously collected data or specimens must be consistent with the scope and terms described in the original informed consent document. Please bear in mind that a consent form is documentation of the consent a participant has provided. It is not consent itself. Their consent is really an ongoing process, and when their samples were donated, their consent was to use these samples in a specific way outlined in this form. If I want to change that in the future, I can't do it without going back to them and getting their permission to do so. Boy, that's really clunky and really inconvenient. So my advice to you, if you're developing a repository, is to write your purposes as broadly as you can that you can anticipate. But I challenge you to understand exactly how we're going to want to use these samples 20 years from now. Because we're going to have methodologies available to us then that we can't even conceive right now. So it's really tough to try to be narrow in your uses and then adapt them for later purposes. So what's not human subjects research? Laboratory research with commercially available tissue specimens, cell lines, or other human cells. So if you're buying the samples from a commercial vendor, it's not human subjects research. Research with autopsy and postmortem specimens is not human subjects research. Research with previously collected anonymous data or specimens. So if these data exist and they are completely anonymized, whether they were collected in an anonymous fashion or they've been fully de-identified and there's no way to link it back, that may not be human subjects research. Research with previously coded data or specimens where you don't have access to those identifiers and codes may not. Here's the fun part, folks. You are going to really struggle to figure out what is and what isn't human subjects research. Fortunately for you, we have an office who does this for you. If you're going to do research with samples and you want it to be exempt and not human subjects research, work with our office and we'll give you a determination that you do and have to comply with IRB if it's human, and if it's not, we'll say it's not and you're good to go. Now you have documentation that you've gone through the process and that you're not breaking the rules. So that's the simplest way, I think, to involve that. Research with FDA regulations. FDA has some specific things that are different than other groups. You better know who your sponsor is and what they specifically require. Activities involving data or specimens that do not require IRB approval under DHHW must still receive IRB approval if activities are subject to FDA regulations. So if I'm doing something FDA and it might not otherwise require an IRB approval, FDA may require an IRB approval anyway. So sometimes the rules change a little bit, so it's useful to know your sponsor. And I'll be honest with you, you're not going to know all of these regulations because they change all the time, which is why we have a regulatory staff whose job is to stay on top of this, who can give you good guidance when you need that help. FDA regulations do not permit for waivers of informed consent. So if you're doing stuff with FDA, it has to be informed consent. Exempt research, research that is exempt from having to do an IRB. Again, this is something that you contact our office and we'll make a ruling of whether you're exempt or not. You can't figure this one out on your own. Research with existing data or specimens, if all of the following conditions are met, can be exempt. So they were available, and the language we use here is on the shelf when you ask for a determination. So you can't ask for exempt research of samples that haven't yet been collected. These have to be already available on the shelf when you want to use them. The sources are publicly available, or the information recorded by the investigator doesn't allow for the ability to link to identify the identity of the participants. So truly de-identified samples. So when the investigator got them, the investigator can't tell whose they are. You as the investigator can't de-identify it yourself and then call it exempt. So this has to come to you in a de-identified way. And again, the research is not subject to FDA because FDA doesn't let us exempt on these kinds of things. Transferring data and biospecimens. If we're doing it right, we're not the only ones who are using our biorepositories. We're going to collaborate with people in lots of places with lots of ideas to get the best answers. And that's going to mean that some of the stuff that you have has to go to somebody else. You've probably seen there's a handout in your materials about a material transfer agreement. You have to think about the transfer of data and specimens and how that's going to be managed. You typically have to have some regulations and some requirements in place that are going to define who can use it, how they can use it, and can they pass it on. Because one of the things you have to be very aware of is secondary transfer to a third party of these samples. For example, if you've read the book, The Immortal Life of Henrietta Lacks, and if you haven't, you should. It'll change the way you think about some of these issues. Her cells that were originally harvested in 1951 and became the first ever cultured human cell line that made it. Well, the investigator shared them with everybody who wanted some. And they shared them, and they shared them, and now no one has control of how these cells are able to be used. Informed consent. It is OSU's policy that you have to give informed consent if you want to put samples in a biorepository. We don't waive those anymore. Consent has to be obtained for the collection and storage for future research. You should clarify what those future research parameters are, if there are any. Is it future unspecified, sky's the limit, wild, wild west? Or is this limited to just this particular topical area? However it's collected is the only way the IRB will let it be used. HIPAA authorization is required if you have PHI in there. The consent has to have some clear things to help your participant understand what you're going to do. So what are you collecting, including how much? We're going to collect a sample, doesn't sound bad. When you tell them that you're collecting a 200-gram sample, that's a little different story. How much are you collecting? Where and how are these samples going to be stored? How are they going to be used? Who has access? Who can they be shared with? All things that really need to be spelled out within your consent form. And maybe you spell it out simply to say future unspecified research. So we're not sure how they're going to be used, and we don't want to box ourselves in because we may come up with something that in the future that would be great to use these for. That's okay. You can say that, but you have to say that it's unspecified. You have to tell them what the possibilities are. Now, you can't conceive all the possibilities. Future unspecified is broad enough to let you do that. You also have to address the risk to the participants in terms of procedures and data. So confidentiality of data is something that we all pay lip service to in our protocols, but in some cases it's a really big thing. And people have some worries about some of these kinds of things for confidentiality reasons. Some other considerations. Pediatrics. If you're collecting things from children, you have to have some assent from the child, not just permission from the parent. GINA language. If you're not familiar with GINA, it's the Genetic Information Non-Discrimination Act. Our government has established rules about limits on how genetic information can be used against people, particularly with things about health insurance. And if you are doing genetic testing, we almost always require you to put some template GINA language in your consent. So we have that language available for you already so that you can just copy and paste that right into your consent so that it covers that. Commercialization language. Boy, people are really uncomfortable with the idea that their stuff might get sold to a commercial entity to make money off of it, and they're not going to get a penny for that. If that's a possibility, you have to say it. Who has ownership of these samples? The reality is that your donation is a gift that you are making to the university and to these investigators for future use, and they're going to figure out how to use it. You need to write it in such a way that the person doesn't come back later trying to sue for a commercial interest in the products developed using their products. By the way, have you realized that people have caught on to this? And some people with some very rare kinds of conditions have actually started doing things like trying to patent themselves and license their stuff to you to use under a commercial use agreement under which they get paid. So if you're smart and you have something weird, there's a money-making opportunity here for you. Autopsy consents. We can't use autopsy samples without the consent of the family. Research using previously banked or other specimens, boy, that stuff really gets hairy. Because if there's a consent, we have to follow it. And if there's not a consent, you may not be able to use these samples. That's some stuff that we've hammered through here. Patient withdrawals and what happens to the specimen or data. If it's de-identified, it's never coming out because you don't know which one is theirs. If it's coded, you have to give them the opportunity to withdraw that. So trends, changes. I think we'll probably just roll this into our panel discussion. So we're going to sort of open the floor up here to any questions that you want to ask, and we'll try to address those. We've got some pretty good expertise on this panel, but I think to help people, and particularly the panel, understand your frame of reference, when you ask a question, please help us to understand your frame of reference by telling us, what institution are you from and what role are you in? Are you an investigator? Are you a clinician? Are you both? That helps us a little bit to understand the nature of your questions. So at this point, I'm going to go ahead and just open up the floor for questions, and we'll see how we do.
All right. All right. Yeah. My first question, I suppose, is whether non-human subjects research is a category of exempt research, because it seemed to me when you gave both definitions, they seem very, very similar. I'm not sure if it makes a difference of where the samples are coming from. So to answer your first thing, sorry, I'm a cancer epidemiologist. I went to James and OSU College of Medicine. Oftentimes I'm interested in obtaining samples from a previously conducted study that was not done here. So maybe part of it was, but the overall consent, these are, I think, what you call coded data rather than, or limited data sets. I don't know who the people are, but a code exists. I'll never get that code. So ultimately, when I want to go get some of these samples, study them in relation to, say, cancer risk or death from cancer, that sort of thing, as an investigator, my understanding is I go through the process where I apply for exempt research. And then I get a letter back saying that's not exempt, it's not human subjects. So I get a little confused on A, the difference, and B, is there a way to better, unless I missed it, is there a way to essentially allow us, the investigator, we're never going to be, and I understand this why, we're never going to be trusted to say this is not human subjects research, I'll go do it. And I don't think that we should be. I wouldn't defend that. But there should be otherwise a category for me to apply for not human subjects research, have a quick review, and then somebody just gets back to you, correct, it's not human subject research, have a nice day. Otherwise, I'm applying for exempt research, and somebody tells me that it's not human subjects, which is confusing.
So in the first part of that, and
I was gonna
you
say,
guys
I
go ahead
can-
and jump in.
I was
Go ahead,
gonna say I
Sherry,
can
you
take
can take
that.
this one.
So there's 3 separate sort of categories. There's not human subjects research. There's also not engaged in human subjects research, where there's a project that's human subjects research, but we can say you as an OSU investigator is not engaged, and that means no review through our office. There's exempt research, which means it is human subjects research, but it's exempt from the regulations and the requirements of IRB review. And then there's IRB reviewed research, which has expedited and full board. So when you have something that you think is not human subjects research, you're right that there is no formal process through our office, because there are lots of things that aren't human subjects research, and we couldn't possibly review all of them. And it is true, you're thinking data and specimens, medical research, and so yours is a little more specialized, but there's tons of other types of research that doesn't come through our office that might involve people or even people's information that don't meet the regulatory criteria. So what people do when they want a formal determination from our office, if you have submitted a few exemption applications and you've gotten back this is not human subjects research, and so you have another one that you think is really similar, you can email us, most specifically me, usually, and I'll take a look at what you're doing, what your role is, what the project as a whole is, the data points you're receiving, and sort of help you walk through what kind of application you need to submit, if any. And a lot of times people need a letter for funders or other things, and I'll write a letter that says, we looked at this, it's not human subjects research. And that's different than an exemption, because as I said, an exemption it's human subjects research, but it meets one of the exemption criteria. No reviews required.
Well, it's an odd thing, because looking at the definitions between not human subjects and exempt, if I'm using limited data set from specimens previously collected that are not identifiable to me from a completely different institution, or 44 different institutions as an example, to me, in my brain, it qualifies as both of those. It actually answers the definition that you put on your slide for both exempt and non-human subjects. And I don't, not to get into the semantics of it, but
the regulations do
Yeah.
have some strange gaps like that. So the thing to remember is the first thing that we do is we determine if it's research. And then we determine if human subjects are involved, if it is research. And then we apply the exemption categories. So we really shouldn't even be looking at the exemption categories until we've gotten to that point. So sometimes there's some things that overlap, but only because you've already made it through the first 2 definitions, and then there's some extra carve-outs. And so that does seem confusing, because if you jump to the exemption categories, you go, well, I could be exempt. Well, yes, but you shouldn't even get to that point. We should be at not human subjects research at the beginning.
It's
I
a
guess
flow chart approach as we have to look at it.
that's interesting, because that flow chart might be helpful for me as a new. So I'm a new investigator, and you're Sherry, right?
Yes.
So you and I actually we went through this, and I even emailed you. And I basically said, so wait a minute. Once you come back to me and you say it's not human subjects research, I actually emailed you once and I said, did I do this right? Was I supposed to apply for exempt when it's not human? You can see where it gets confusing,
Yeah.
especially for someone new. I just wonder if there's not a way to streamline, maybe just email,
Yeah,
can I
that's
just
the-
email?
that's the
Because otherwise I'm
process
filling out the whole form to find out I didn't need to fill out the form, which in my mind,
Yeah, you can
I
not
feel like-
fill out the form and
Yeah.
contact us first to start with once, if you think that you don't fit the requirements and you think
Yeah.
it's not human subject, but you want to make sure that's the right answer, you can email our office and we sort of take you through that. We've been
That would be
working on
fabulous.
tons of different things. One of the things is to sort of have an easy intake form that says, I want a determination. But what starts to happen is, and from your back and forth with me, you can see like it always depends on the situation. So we ended up with a form that was almost as long as an exempt application. It's like, well, why create a form when half the questions aren't going to apply depending on who you are and what you're asking? So we really do just for the non-human subjects determination. And if you think that OSU, like you're not engaged, like your role is only the analysis of like somebody else in the project has identifiers and they're at another institution, they're just sending you coded data stripped of the identifiers for your analysis, and that's your only role in the research. People contact us for determinations that they're not engaged also for that. And so sometimes that's
If I could just ask one last thing, I'm sorry to monopolize. I actually find this fascinating, and especially now that I've done it. Do you guys, when you put these things together, are you in communication with the people like myself who will be confused by it and who will be submitting these things? Because ultimately, some sort of crosstalk. I mean, this all makes perfect sense, but it wasn't there for me to understand from the best that I could glean from the website and so on. It would feel better. It would feel so much easier if I understood. And I'm a big defender of this sort of thing. But even then, going through it, I kind of felt like lost and adrift.
So when you look at the magnitude of an institution like Ohio State, at some point that becomes not feasible to do. So we try to do it on a smaller scale. And we do that by, in some cases, forming working groups to look at issues. For example, the Biorepository working group who helped develop our policy a couple years ago had people from the ORRP office. It had some people from the IRBs. It also had a couple of investigators who work with biorepositories who are on the policy development committee. Also, when we're making big changes to policies, those policies are reviewed by an IRB policy committee, and that policy committee has investigator representatives on it. So that's the mechanisms where we try to get that, but the reality is we can only do that on a really small scale, and we're always going to have some things that are here. What ultimately happens with any of these is if you become what we lovingly call a frequent flyer, and you do this kind of stuff all the time, you know your pathway. It's a pretty well-trod pathway. I know this one's going. I need this form, this form, this form, and they're pretty streamlined. For example, the AIDS clinical trial group is a really high-volume, frequent flyer group that sends us stuff all the time, and they really know the pathway because they do it all the time. When you're a little newer at this, or if you're venturing into an area you haven't done before, give us a call, send us an email, let us save you time. I think that's maybe the best message I can give you. We can point you in the right direction.
And we are developing, since the policy and the working group and everything in our new, we have some new guidance coming out soon that I think will help with some of this. And then also, the problem right now too is we're very focused on creating our electronic application system right now. So a lot of the resources that we could, that we're spending are trying to develop resources to help people use that as that comes out, and then, staff time on that. But we do try to chip away at providing guidance documents and things like that. And pretty soon we already have the banking and biospecimen guidance for protocols out on our website, like how to write a protocol, and it has the sections. Pretty soon we're going to have some information on use of secondary specimens and that sort of thing. So it is forthcoming, and we do know it's confusing. But right now, the best way is, if you're really confused, is to email me.
So the message is the IRB is your friend.
Can I add one thing too? You can find those flow sheets, the Department of Health and Human Services website. If you go under 45 CFR Part 46, you can get the flow sheet she was talking about, where you can say, is it research? Is it human subjects research? Is there interaction?
I think I actually did that once
Okay.
upon a time, but it led me to exempt rather than not humans. I don't know why.
Well, there's several flow sheets attached to that, and you have to kind of
It's a government document.
Yeah, it's
And then you add to that our policies, how do we define
Right.
de-identified, how do we
Yeah.
define this, and then
Okay. Down here in front.
I'm Marjorie Kelly, and I work in biomedical informatics, and I've been here since dinosaurs roamed the earth. But I take exception to your first statement that you said, that we're the bad guys, because I think of these guys as my collaborators now. So before I even begin the process, I go say, this is what I want to do, help me do it. And it's a conversation over the course of 4, 5, 6 months sometimes with the big registries, and once you get international registries and whatever, it takes some time to do that. But If I'm
The
collaborating
bad guy's
with one
comment
or
obviously is
somebody-
tongue in cheek.
Well, all
But,
right, I'm just saying, don't even say it, because that's,
Mm-hmm.
so that's been kind of my workaround for biomedical informatics, and it's actually been great.
Mhm.
So you guys have been nothing but wonderful.
Mm-hmm.
I appreciate it.
So, question over here on the side. We'll let him get the microphone so we can all hear. Oh, you've got one first. Then we'll just pass it in a line.
Okay.
It'll be efficient.
So I am a new investigator in the James. I'm a PhD investigator. I've never written an IRB. I'm interested in working with biorepositories. Every single IRB training session I go to, I've asked, do you have a template? Do you have something I can work with? Do you have something that I can start with? Can I see something that's an IRB for a biorepository? And the answer is always no. And I think that's really scary for someone who doesn't have any experience doing this. I mean, I have no idea what I'm shooting for. It feels like I'm shooting in the dark. So are there any resources out there to try to help me get started?
Well, we do have on our website a template for making, for creating a biorepository, the elements that need to go into it. Our policy is very robust as far as the elements that the institution requires to be in and the considerations, the consent elements that are required. A lot of what was in this was sort of pulled from the policy as far as the elements to consider. The guidance on the website goes a little further and discusses some examples of things to think about. We do have some more forthcoming guidance. The problem with an example, and as you could see from some of the earlier presentations, is that people are all over the place with biorepositories, and really the best thing to do is find someone that has a similar scope biorepository, that you're thinking of creating, and work with them. We have sent people, to work with the folks that are creating the total cancer care protocol. Sometimes people end up wanting to just collaborate with them rather than strike out on their own. Our policies are newer, such that some of the older established ones, we're working on getting those into compliance with current policies, so that's another problem, that we can't just point you to some of the existing ones because they're not quite there yet, where our current policies are. So NCI has a really fabulous, very long, very detailed guidance for setting up a biorepository that even takes you through all of the SOPs you might want to think about. So that's a resource that you could look into also.
The thing we can't do is we can't just give you a copy of somebody's that's already approved for confidentiality reasons. But one of the things you have in your materials is you've got a list of some of the biorepositories that are here. You can ask them to share their materials with you. We can't give you their materials, however.
Are you allowed to put us in contact with people who have, if we explain to you what our repository might look like, are you allowed to put us in contact with people who have similar repositories?
Yeah, I mean, if you send us an email, sometimes we'll email out and ask people if they're willing to be contacted, that sort of thing. And then we also have some people on the IRB who either by nature of reviewing tons of repositories or because they have their own or are affiliated with their own are willing to work with you also. So if you send us an email with what you're looking for, we can try to find someone to help you.
Okay.
Yeah, I've done a handful of those consults already. Some formally and a lot more someone in the hall grabs and says, hey, you know about this stuff.
Hi, my name is Darwin Conwell, and I'm a clinical researcher. I have a two-part question. We are looking at data that's publicly available through the government, such as the nationwide inpatient sample and NHANES, and this is all de-identified information. So my first question is, how do you classify that type of information? And number two, what is the statement that we should have in regard to the IRB on manuscripts that we publish as Ohio State investigators?
So those types of data sets, just like the repositories that collected them, are all over the place with their own requirements. So you have not only our institutional requirements, but also sometimes, even if we would determine something not human subjects research, you have requirements. RAND is one that requires IRB review of safety plans and all sorts of things, even for data sets that we would consider not human subjects research. So then you have people who are getting public sets that still have IRB review, and it gets confusing. Some of those data sets also have restricted use versions where the person handing them out, NHANES is one, where they will hand out things, and certain data sets are public, where anyone can get them and they're willing to hand them out. And they don't consider them potentially identifiable. There's been enough fields redacted that they don't feel like statistically it's likely that someone can re-identify these materials. Then they have versions that get more and more and more potentially identifiable. So that's one of those, when you're going to use a publicly or a public data set, it's one of those things where people email me, sort of like your question. They email me and say, here's what we're getting. And a lot of times I'll clarify, is this restricted? Can you get something from the person providing the samples that says, this is we consider this to be a de-identified data set. Sometimes you'll contact them and they'll go, oh no, we want you to get IRB review, like regardless of what data is in it. So if it comes to the point where they say it's de-identified and you check with us and we say yes, then what you should be calling that is it's not human subjects research. So on grant applications or anything else, if you're going to analyze it, don't check the box that says this is human subjects research and exempt, which was what a lot of people do. You're not even dealing with human subjects at that point, according to federal regulations. So you don't even indicate that you're doing human subjects research. But there are a lot of variations on even like the NHANES and everything else. And so it's recommended that you either work through us or get a statement from the person providing the data. And some of these bigger ones are IRB reviewed that says, this is considered completely de-identified. And then we can give you a letter that says no review is needed.
Other questions?
I'm Holly Borghese from College of Veterinary Medicine. I was glad you brought up Henrietta Lacks because I was wondering when we saw that cycle how the effect of Henrietta Lacks and the history in general and the African American community has affected the disparity of healthcare now. So how is this information getting out there so that you get more consent from African Americans?
Well, that's a great question, and I don't know that I have a good answer. I think that book, when it was published in 2010, and it became a New York Times bestseller, has profoundly impacted this kind of research. And it's profoundly impacted it with people who do this kind of research and with IRBs. In fact, in 2012, that book was the freshman book club read for this university. So it's something that's been discussed broadly with all of those incoming students at that period of time. But to see that trickle into some of the underrepresented communities, well, you know what? A lot of folks in those communities weren't freshmen at Ohio State in 2012. They may not have a good feel there, but they do have a profound distrust, and a well-merited profound distrust of the way investigators work with them and in some cases deceive them and mislead them and have done some pretty unethical things. The reality is it's really hard to do work in communities until you develop a trust and a relationship within those communities. And sometimes it's best, if you want to get started in those communities, to tie in with somebody who already has a connection. I have a colleague who does some work with concussions in low socioeconomic status groups. And one of the first things that she did is she tied in with the public schools and through the coaches, and she's tied in with community groups and local churches. And she goes out and does a ton of talks just to the people in the community, saying, hey, here's who we are and here's the stuff that we do and we want to partner with you, and starts to develop a relationship. And from that relationship, she develops opportunities later on. But if you show up in your white coat and you ask for stuff, you may not get real far. It's a little at a time, and I don't think we've done a very good job comprehensively of trying to bridge those divides.
Real quick question then. Is that population represented on the board, IRB board?
The board is fairly diverse. I don't know that we've actually taken a poll and looked at that, but as I think around the room, as I'm sitting in the front of the room, we actually have people from a number of different areas. Low socioeconomic is probably not one of them. And actually the single hardest place to get members for your board, I'm sure you run into this as well, is getting the non-scientist, non-affiliated member. When one of those folks goes off, it's a scramble trying to find another person who has the time to be able to devote and who has the interest to be able to get involved in some of those topics. You know, I know that one of the folks that we recruited, I helped recruit, actually was an associate pastor from my church, who a very different background than any of us here, and brought some valuable things there. But I don't know that we've made good hard inroads into trying to find a member from that community, and that might be a very good place for us to go.
I also want to add too, I know there are community outreach groups in the city of Columbus, because I gave a talk not too long ago. We have a group that's stemmed out of children's, but for the African American community in particular, and gave talks to groups where they invite people from the surrounding areas, and I'm not sure exactly where they reach out from. So it is something that IRBs are concerned about, and with accreditations for IRBs and things like that, it's not something that's not being looked at. And it is true, we have several community members on ours because we have different levels, and word of mouth, if you know, we ask people if you know someone who may fit what we're looking for. We're interviewing people all the time, so we need your help also, you know, in saying we have this deficiency, or, you know, there's an area of research, and the IRBs they're cognizant of that, and we look at who our members are too.
I would add too that the IRBs often, even if someone's expertise is not on the board, they have the ability to look for external consultants, either consultants on the actual review process, which does happen with a lot of research, especially with vulnerable populations. But also, the board has required that the investigators themselves collaborate with community groups who are in different types of, you know, certain communities, work with community leaders, and actually add those people to part of their protocol process, so that the board knows that they are being sensitive to the needs of the community. And so that's something that happens too, even if there's not a member on the board that has that specific expertise or is a part of that community, that person becomes part of the protocol and part of the research team.
And the CCTS has a community engagement wing, including a community engagement board, and you can contact us and we can help you make connections into various communities.
There's a question over there.
Can you give us some idea of turnaround time for protocols to the IRB? I've been here for 12 months, and what's your ideas for turnaround time, and you know how this impacts the investigators? And
Well, you came here in the worst 12 months that are possible. Our turnaround times have been the slowest that they have ever been right now, and that's largely because we have seen a massive expansion in the number of protocols that we have. Some things that we have done relative to that is the IRB has recently brought on and trained a number of additional staff. When you look at our staffing levels to protocol number levels, we're in the bottom quartile of a lot of major research institutions in terms of IRB staffing, and that's really been a barrier. So we're seeing some changes there, but you know, I think the last numbers that I heard, we were running around 8 weeks. Those may be coming down a little, and here's the really fun part. They are starting to come down. We're clearing some of the backlog as the new people have come through. But we're about to go to a fully electronic system, not just submit a PDF, but almost the TurboTax approach to doing an IRB. So it's going to walk you through the steps. And the big thing that that's going to do is eliminate a lot of the mechanical review pieces that our staff have to do as they come in. So we're very optimistic on where these turnaround times are actually going to go in the near future. But we are certainly a lot slower than any of us would like to be.
I just think it's obviously it's very, very important for us, and I guess I did come at the wrong time because you know, I've had a couple of protocols really delayed, and it does impact funding down the road because we're all up against deadlines for resubmitting the next grant and all that, and so it really impacts us greatly, the turnaround time.
It impacts us too, because some of us are also investigators. So we're feeling your pain. In the back.
Hi, I'm Irene Albanese. I'm at the Nationwide Children's Hospital. I have a question for you. So I have very good experience with the IRB. I actually sent because we enroll pregnant women, I've sent my IRBs to OSU, and I had great feedback, and they were complicated. But I noticed that the IRB just adds another form rather than take a form out. So instead, so now since you are going to the electronic system, I think there should be a little mindfulness to the time of the investigators and not having redundant information over and over put in the same boxes. So, I mean, it's not only at OSU. I think I have IRBs at Nationwide Children's, and it's pretty much the same. There's a box where you have to say privacy here, and then you go in another port, and you just take the same wording and you put there. It just takes so much time. So I think it would be nice for the IRB to consider that we have grants and we have students, and every minute that we spend on an IRBs that we have to write is very expensive for us.
I guess I would say that in building the electronic form, it is supposed to be more of a smart form. So some of the sections go away that don't really apply, where people would be trying to answer them before because they didn't quite understand what the question was asking. We also tried to add more information to more information boxes that will precisely tell you what we're looking for. For instance, a lot of people think the privacy and the confidentiality sections are redundant when those are two very separate considerations that the board has to look at. You know, privacy, the access to yourself, and confidentiality of the data that you collect. And sometimes people conflate those and they're writing the whole answer for everything in both places when really they should be divided. So, I mean, we did try to take that into account. Some things collapse down. Some things, if you mark it once and upload forms, it's going to appear in other places. So we really did try to take that into consideration when we were creating the forms.
I don't want to give you an idea that it's all things to all people. It's going to be our first iteration of this. It's gone through beta testing, but I guarantee it's going to have some bugs, and it's going to have some frustrating things. It's better. It's quite a bit better than the way we've done things in the past, but we're still going to trip up along the way. And as always, please bear in mind, IRBs are peer review. We've all had that journal manuscript or one set of comments thinks it was the best paper you ever wrote, and the other set of comments thinks it should be rejected flat out. It's going to be that way as you go through an IRB process as well. So bear with us on those. We try to sort those things out and try to make them as clear as we can, but it is certainly a peer review process, and there's always going to be some degrees of inconsistency as you go through it.
I think one of the frustrations too is we tend to be the last in the line, and just remember, I mean, it's the first time the IRB has seen something, and we know that there have been delays along the way, maybe getting protocols signed off or getting approvals different places. But it's a really important last step, and just if you think back to the protection of human subjects, that's really where we're coming from, and we try, I know at Children's also, not to do duplicates if we can help it, but sometimes it's unavoidable. Things branch from one question, will branch then to another form. If you're having children involved, you're going to branch to protections for children. If you have prisoners, there's a separate page, so I'm sure that your electronic system here at OSU will be the same. So sometimes you can't help it, but it helps increase the accuracy of what we're reviewing. And in the end, you know, our determinations are only as good as the information that we've been given.
And in many cases, those forms, the material on there is for compliance with a particular regulation. And while you may have it somewhere else in the protocol, we're looking at that regulation, I need all this information in one place to make that efficient for the review. Because if your reviewer has to hunt around for a lot of stuff in a lot of different places, I've seen 1,000-page protocols that have come through us by the time you have all the materials together and everything. And if I've got to go hunting for which page was that on somewhere else, that really slows down the review even more. Last question. I think we're really getting short on time.
It relates to the question of how long things take to be reviewed. The CTSA actually has one of their goals is to shorten review times. And we have done surveys and compared us to other IRBs. And it's always apples and oranges because everybody counts days differently. But one of the things we found here was that 70% of protocols get sent back to the investigator because their conflict of interest or their city of the people listed on the protocol were incomplete. That's right away a 2-week delay in the submission because those two simple items. Now the electronic one will help Now, actually, our time frame will speed up by 2 weeks on the average, because with an electronic form, you can't even submit it until that's been certified.
Correct, yeah,
And
it'll
so-
vet it for us.
And so literally, this simple mechanical thing of changing from one form to another will speed up our review. The second thing that's not reviewed is some IRBs, actually, when the IRB reviews it and sends it back to the investigator, they call that a timeout. And that time that the investigator holds a protocol while they review it or update it and send it back is when the clock starts ticking again, because then that's IRB time and not the investigator time. So it's really very difficult to compare. But the bottom line was, when we compared our place to other places, this was 2 years ago, we were in the middle. We're not any worse than anybody else, not any better. But in a group of about 60 centers, we're about average. Things
would
may
al-
be slower now just because of the personnel
Yeah, the
changes.
change,
but-
turnover, and an
Right.
increase. One thing to remember too is that, you know, you can always communicate with our office if there are really important issues at stake, you know, people who are going to graduate. Obviously, if we have 50 people asking, you know, for special favors, someone's still going to be 50th. But, you know, to use that judiciously, but sometimes things come up, you know, sometimes the circumstances beyond your control or things need to be made. And I would just encourage you to communicate with our office, because we can't know exactly what the timeline is without reviewing it. And so, you know, like when something comes in, we don't know that a funder has put some sort of kind of sometimes unrealistic deadlines on, we only just told you got funded, but now you need review by tomorrow. And if you communicate with us, like I said, you know, sometimes that leads to abuse in the system, and we do try to service people first come, first serve, so that we get everyone who's funded, unfunded. But certainly life happens, and, you know, I would just encourage you to communicate with us so that we know that you have a timeline, rather than waiting until one day before it's due and then say, well, but I have to have this reviewed by tomorrow, because then we can't help you. We can't pre-screen part of it to make sure there's not simple things you could take care of now before we actually get to the full screening, or before it gets to the review.
Please don't cry wolf on that. We've had a lot of people say, oh, my funding's coming up, I need to go up. And we've had enough of those now that we're sort of looking for some verification that indeed your funding really is dependent on this timeliness.
Because sometimes we can just write you a letter that says it's in process. They don't actually need the approval to get things started. They just need to know that you are in process, and we can write those letters very quickly for you.
I think she's got one more. We'll go.
I was just going to say something about the NIH just-in-times and how hard.
Yeah.
You may not get, you know, your funding's being delayed. They may argue, you know, special. Anyway, it's just
Yes.
frustrating.
It is on all cases. So we're doing our best to try to accommodate those needs as we find them, and the timelines should really come down quite a bit over the next 6 to 8 months, I think. So we're pretty excited about what you're going to see there. Well, folks, thank you very much for spending some time with us. Your lunch is getting cold. So we're going to go ahead and wrap it up. But if you have additional questions, we'll probably hang around here for a few minutes if you'd like to bring
Back here
those up.
for you.
Thank you very much.